Well, thank you all very much. I too want to join in welcoming everyone here. It's a tremendous gathering to have so many of you who are involved in Li-Fraumeni syndrome one way or another to be here in the same place, talking together, working together, and focusing energy on this one topic. And I'm very thrilled to have a part in it. I'm beginning to think that my choice of topic is really not a very good one because you all could be telling me about it as opposed to my talking to you about it. I have changed it a little bit. It's going to be more about the evolution of LFS from 1969 to the present. And then the rest of the conference, I think, to a major extent, will be focused on where it goes from here. I was around in 1969 when Li-Fraumeni published their first paper, and was very fascinated by it because my interest had been childhood cancer genetics. Joe Fraumeni actually had a history of papers on childhood cancer in siblings, so he had thought about this in a number of other settings before this particular Li-Fraumeni work came along. Matter of fact, Joe has actually told me on many occasions how initially, when they found these unusual families with this aggregation of cancer, that it must be something environmental. You know, genetics wasn't big in cancer those days. So they followed the families for some years, and by following over many years, looking at different branches of the family, it became apparent that new cancers were occurring, whether they moved, whether they lived in a different environment, a different job, they were part of another cousin that hadn't been in ever the same kind of location. And the idea that it might be genetic became much more appealing. So I think 1969 until sometime in the 70s and 80s, people were interested in the genetics, and others in the US and Europe began looking for families that had the same kind of tumors that Joe and Fred Lee had described. And everyone was trying to come up with some kind of criteria. What is this thing? Okay, we're calling it Li-Fraumeni syndrome because it may have this, or this tumor. And everybody was ascertaining patients somewhat differently from the patients to whom they had access. So we had several different competing criteria or definitions. So it was just something that was very difficult to kind of get your arms around. And I think that's part of the reason that for so long, the nearly 50 years, that a big part of that time we didn't make a lot of progress because we didn't really have a good handle on it. In the 1970s and 80s, we began to get a little more kind of sense of what this might be, but it was still not defined. I think 1990 was a pretty big game changer in this whole process of what is Li-Fraumeni syndrome. It was a pleasure to be working with David and Steve Friend and Judy Garber in working to identify the p53 germline mutations in Li-Fraumeni syndrome, and to suddenly have something that we could have an arrow at each end. We have p53 germline mutations, and this may be the underlying cause of Li-Fraumeni syndrome. Now, you didn't have to wait till a large number of individuals in a family had cancer and could present a picture that others might recognize. You could actually test individuals. But in 1990, most individuals did not want to have anything to do with testing. Amanda, you were not the only one. People said, why would I want to be tested? You can't tell me anything I would do about it. And in those days, we didn't have GINA, the Genetic Information Non-Discrimination Act, which didn't come along until the early 2000s. So the other concern was, what if I lose my health insurance and I get cancer? This is a double-edged sword. We're not going to go there. So testing was slow for a little while, but over time, testing was often done on a research basis so we could learn more about what the cancer risk really was and be able to give people some better information so they would have some idea of what would be the best opportunity, the best thing to do. In my group, we did some studies where we studied the families of children who had soft tissue sarcoma. Yes, Amanda. And we were interested in not waiting until we had a big family. We took a whole cohort of childhood sarcoma patients and collected the family history information actually in the 80s and early 90s. And then with P53 testing, we offered testing as a research study to all of the families. Our plan was to try to identify where these mutations came from. Were some of these children new mutations that had never been in the family before? Could it be passed on for multiple generations? To try to get a little better background on where this was coming from. So anytime we had an individual in a family who carried a mutation, we then, if possible, tested their parents and their siblings. What we found was that mutation carriers showed up in people who didn't have their first cancer before the age of 20. Mutation carriers showed up who didn't even have their first cancer before the age of 70 or 80 in rare occasions. We found that there was an incredibly wide spectrum of ages of onset for first cancers, of types of cancers, and of the cancer experience. This is not shown in very many textbooks, but in some of our large families, as many people had their first cancer over the age of 50 as had their first cancer at a younger age. So we don't have any good understanding of exactly how this wide range of variation can occur, but it does mean that we need to look at a bigger picture than in many cases we have been in the past, because we can detect early cancers in some of these older people and prevent the burden that might occur if it were waited until a later stage of disease showed up. We see, as I say, a very wide range of tumors that are beyond what's the typical spectrum. We see lung cancers, we see prostate cancers, we see all sorts of GI cancers, endocrine tumors, just a very wide range. So it's a sort of thing that you really have to keep an eye out and some index of suspicion when there are more than one cancer or when you have more of the more classic familial cancer syndrome. So we learned a lot of this in the 90s with all the genetic testing. 2000 came along, and we were still kind of looking at things like what were risk modifiers. We know P53 interacts with many other genes in the cell. Matter of fact, it binds with all kinds of other proteins. And so the question was, are there things that other genes that may vary and they may affect how P53 functions? And yes, we found that some of the variation could be accounted for by risk variants in genes that interact closely and regulate P53. But that couldn't begin to explain the wide range of variation, even in a given family. So we're still, it's still an area of investigation to try to understand how the range, when you carry the same mutation, can be so broad. The next major breakthrough in my book occurred in 2011, and there were a couple of major things that occurred in that year. As you've heard a great deal about the Toronto protocol and the first screening study that showed a significant survival benefit in LFS patients. That was really a major breakthrough. It gave everybody hope that there was some opportunity to cause a change, to provide survival benefit. And now you'll see variations on this protocol popping up all over the country. We've instituted in our institution in our first early stage of looking at the outcomes. Close to 10% of our patients, or actually a little over 10%, I misspoke, were found to have some invasive or potentially invasive cancer. So it really can be productive. These are all individuals who were able to be treated primarily by surgery without radiation and chemotherapy, and to me that's another big win. The other thing I want to bring up about 2011 is that was the first LFS conference with investigators, providers, and families. That was an amazing experience. You've heard reference to it earlier today, but I want to give it to you from the other side. I wasn't one of the LFS patients. I was a provider there watching what happened. The first day we had talks, didactic talks like this, but the second day we met separately. The investigators and clinicians worked together on one side talking about what they were going to do next. The other side, the families met. Most families at that point had never known another family with LFS. In some families, this was kind of considered maybe something of a stigma. They didn't talk about it. They certainly didn't want anybody to know about it. After this group of families was together for about the first half day, I think we had another joint meeting. And it was a whole different ball game. It was as if everyone had known everyone forever. Everyone had told their stories, and the stories were familiar to everyone. They were talking, they were getting organized. This was the birth of the LFS Association. They'd elected officers, they had goals, they had plans, they were raising money. It was an entirely different world, the energy that came from that communication, from that gathering. And I emphasize this because I think that this has really been one of the major breakthroughs in LFS world, because without communication, whether it's within families, from within the medical community, or within the combined groups, it's much harder to make progress. Most of us talked after that first meeting and said, why the heck didn't we do this sooner? We could have done this years ago. Why didn't we think of that? And I've heard you say some of the same things today too. But in thinking about the things that have occurred between 1969 and today, I think that meeting was one of the most important things because it told us how much we could learn from each other and learn from working together. I think one of the next big things is what's known popularly as big data. And people have referred to it in different ways, but we will be putting together databases so that we'll know if one particular mutation causes more of this cancer type than another, or if it responds, or if those tumors respond differently to a given treatment. Or if there are better ways to identify or treat tumors of a certain mutation or type. We'll suddenly have enough data. We never had enough data when we were dealing with small family units at a time. But now we will have enough data from places all over the world, as are represented here today. And I think that the communication, the sharing of the experiences, the sharing of the data are, as others have said before me, going to be the major hope in really moving us significantly forward in this field. You're going to hear a lot of the good ideas about early detection, about potential prevention, maybe some new screening methods. You're going to hear a lot of that, but if we don't share the data and work together, they'll only be helping a few people here and there. So I would just like to thank the association, thank all the people who have come, thank everybody who helped put together this meeting as well as the first meeting in 2011, and hope that at the next meeting there'll be a lot more new information on big data outcomes and some of the newer approaches to diagnosis and treatment. Thank you.